Welcome everyone. Thank you for coming today. My name is Jennifer Esposito. I am the moderator for today's family support webinar based at the Center for Schools and Communities. It's my pleasure to welcome you to Caring for Caregivers, Supporting Parents' Mental Health. So we want to welcome Bentley Eskridge here with us today. She's the Assistant Professor of Clinical Mental Health Counseling at Newman University and the Director of Child First. It's my pleasure to welcome Bentley here this morning. Thank you for joining us.
Thank you for having me. I'm super excited to be here. Good morning, everyone. I am like Jennifer mentioned, I am the director of Child First, which is a home-based therapeutic intervention program that focuses on building attachment between parents and kids ages 0 to 5 who have been impacted by chronic stress and trauma. In addition, I'm also a private practice owner and a professor at Newman. And my private practice focuses primarily on women and families who are experiencing perinatal mood and anxiety disorders. And so what we'll talk about today is a little bit of what PMADs are and then how we can provide support to families who are navigating PMADs postpartum and peripartum, really. So yeah, we'll get started. Also, like I heard the announcement, I know folks are like sharing computers and like there are a couple people in one setting and that's okay. I am not great with chat. So if there are things you're dropping in the chat, also feel free to like, if you're able to come off mute and share. But super interactive. So if you have questions as we're going through, when I come to the end of each slide, I'll stop and ask if there are questions, and that's a great time for folks to pop in. Please feel free to come off mute and jump in and ask questions or share experiences as we move through together. Want to get started with just a question, and you can go over to Mentimeter. There is the link, there is the QR code for folks that are savvy. If not, that's okay. You can also, again, come off mute and share. How comfortable, the first question is, how comfortable are you with talking about mental health with your family? So we have the options of, yep, I can do it, absolutely. The option of, like maybe if I have to, I can do it. And then the option of, no, thank you, don't want to do it. I prefer someone else to have those conversations. And so there we go. And folks can pop on their answers. And again, if anyone wants to come off mute and share, please feel free to do so. How comfortable are you discussing mental health with your participants, whether they're referred to as like clients or your families? How comfortable are you? All right, so we have very comfortable and no thank you. All right, so that looks really good. We're there's no one that's like, nah, I'm not doing that. But we have a few people that are like, I could use some support and maybe a little bit more experience with it or education. And then a lot of folks that are very comfortable. Great. The next part of that question is, what are some of the barriers that you have when you think about having conversations with parents about their mental health? And again, feel free to pop off of mute or feel free to share in the Mentimeter. What are some of the barriers that you've experienced? Is that one working?
I have a barrier.
Oh, sure.
So one of the things that I've really come up with, especially with my clients, is my clients are often really open about their mental health struggles as well as like things that might be going on in the family. But it's usually their partner or like their support systems that kind of struggle with accepting that mental health is a thing. And it usually comes with excuses, which usually causes my clients to have a lot of guilt and be more silent about what they're going through when it comes to their mental health.
Yeah, that's a great point, Stephanie. Thank you for sharing that. And we'll talk a little bit about pooling and support people and why it's so important to have support people and what support people look like. Sometimes it will be partners and family members. Sometimes it will be friends, and sometimes it will mean going into the community and finding folks that can be supportive. Because one of the things we know is that guilt and shame kind of maintains the stigma and maintains the isolation that's associated with mental health in general, but specifically with perinatal mood and anxiety disorders. Thank you for sharing that. All right, in the Mentimeter, we have stigma, huge one. So if everyone isn't familiar with how Mentimeter works, the more times that a word is shared, the bigger it gets, the more space it takes up. And so the three big ones I'm seeing are culture, stigma, and privacy. Um, Past bad experiences, yes. Access, mistrust, finding available help, embarrassment, anger, domestic relationship, lack of resources. Um, Getting qualified help, not willing to share, ability. Like these are all real barriers that we encounter when we're talking with our parents about their mental health. And a lot of them, again, are coming from that stigma, are coming from that lack of trust, are coming from those past bad experiences that are identified here. Thank you all for sharing. Anyone else want to come off mute before we go into the next slide? All right. All right, so we'll start with just talking about what PMADs are. PMADs, again, are perinatal mood and anxiety disorders. They are emotional and psychological disorders that are present during pregnancy, and what is officially said is up to 1 year postpartum. But what we know is that once someone is diagnosed with whatever mood or anxiety disorder they may have been triggered during their perinatal experience, it doesn't just go away once the baby's born. It doesn't go away once they're not pregnant anymore. These are diagnoses that stay, right? And so even though PMADs are only diagnosable up until 1 year postpartum, we do know that those impacts, those symptoms stay around, which is why it's really important for us to have an understanding of what PMADs are and how to intervene and provide support. Because again, if they're unaddressed, they don't just go away once the baby's first birthday passes, they stick around. So yeah. And it's really important to understand the difference, especially when we're talking about PMADs, the difference between what baby blues are, which is a perinatal adjustment period, and PMADs. So baby blues are very common. Up to 80% of parents report experiencing baby blues. They're usually present 2 to 3 days after birth. They are associated with like changes in mood, tearfulness, irritability, feelings of overwhelm. It's mild, it's temporary, but the most important thing to remember is that baby blues do not impair functioning or bonding. Baby blues do not get in the way of mom and baby's relationship. And we're thinking about what it looks like to support someone with baby blues. A lot of what we'll talk about today is that validation, is that normalization of this is a really challenging period. This is a really uncomfortable period, but it's also really a predictable period. We know that moms and families are going to go through this adjustment. We know that moms are going to have a period of adjustment, which comes along with some of these experiences that they're having. That normalization really helps to bring people in to provide support for mom and baby, but also, again, for them to understand that this is a typical part of adjusting to a new baby. Even if it's an established family, a new baby is still going to come with adjustments, and mom is still probably going to go through an adjustment, which we see as the baby blues. Any questions here about just the baby blues as they differentiate from some of the more, some of the PMADs we'll go through? So perinatal mood and anxiety disorders include depression, anxiety, PTSD, OCD, bipolar disorders, and postpartum psychosis. And again, when we're thinking about pulling in the whole family and providing support to the whole family, it really is a good idea to understand that postpartum depression is just one aspect of what different disorders can present to a parent. And when the whole family, specifically when the parents understand what some of these different expressions are, they're more able to support one another and to bring it to you as those healthcare providers when things come up. One thing to keep in mind is that for all of the PMADs we'll discuss, increased anxiety and intrusive thoughts are present. So that is an experience that comes along with every PMAD. And again, that normalization of it, like we expect for new parents, for established parents to experience periods of increased anxiety and intrusive thoughts. Some of the risk factors are a history of depression or mental health. And that goes for mom and dad, even how some of the kiddos, while children can't obviously be diagnosed with PMADS, we do know that if there are genetic predispositions to mental health concerns, and when a new baby is invited in or brought in, we know that that's an adjustment, and we know that kids can sometimes struggle with an adjustment, and adjustments are also some of those experiences that can activate some of the symptoms related to the mental health concerns that we'll talk about. So the history of depression or mental health is important for mom, but it's also important to have an understanding for the family as well. Another risk factor are low social support. So families and parents and moms that don't have access to a whole lot of social support, whether it's because they are geographically isolated, whether they are estranged from family members, or whether it's just they are a very small family. Birth trauma. So if there was a traumatic birth, if the pregnancy itself was traumatic, if mom was sick a lot, or if mom had to come out of work sooner than she expected, if mom wasn't able to be present with her children the way that she typically is, if mom wasn't able to be present in her relationship with dad the way that she is, all of those are considered, can be considered trauma, and can really impose a risk when it comes to developing a PMAD. Other stressful life events, so a move that was unplanned, or a loss of a job that was unplanned, and then previous pregnancy loss. So families and moms and couples that have lost pregnancies in the past are at a higher risk to develop a PMAD. On the other side, it's really important that we also identify protective factors, because as those supportive folks, the protective factors are the things that we're going to dig into to really provide support for our families. And so families that have a strong support network, and again, whether it is an internal support network, whether they're really connected to their community, whether they're very engaged with their healthcare providers, any type of network that is strong that they find supportive will be a protective factor and something that we can tap into. Folks that have stable housing and financial resources, and again, being really expansive about how we think about stable housing and financial resources. So families that are in multi-generational homes, even if they don't own the home, even if they don't plan on being there for a long time, if they find it stable, we can find it stable. Even families that are in like long-term housing shelters, if they're comfortable in the shelter, as comfortable as you can be in a shelter, but if they're comfortable in the housing shelter and there is a reasonable plan for movement into independent housing, we can consider that stable housing, right? Same thing with financial resources, whether families have consistent income, and if that income is Social Security or cash or SNAP benefits, even though we know that's not as reliable as it once was, but even those things are still considered access to consistent and predictable financial resources. If they already have healthy coping skills, if there's access to healthcare, if folks are involved in culturally affirming support systems, so whether they're really involved in church or whether they're really involved in any other community activities that they feel comfortable and find support in. And also, one of the things, it can get a little weird, because while previous experience with mental health is a risk factor, it's also a support factor. It's also a protective factor. Because folks who have experience with mental health also have experience with navigating those systems. They usually have an idea of what their coping skills are. They usually have an idea of what changes with them when their symptomology increases, right? I think back to COVID and when I was when I was in private practice, and the folks that I had been working with for a year or two who had been diagnosed with anxiety and depression, when we got into COVID, they weren't necessarily okay, but they were prepared, right? They already had access to their supportive skills. They already knew what to expect when it came to like their anxiety or depressive symptoms being increased. They already had access to their coping skills and all of those things. And so while they weren't necessarily okay, there wasn't an escalation in their experience, right? And then I had folks who had never had experience anxiety in a diagnosable clinical way. I had folks who had never experienced depression in a clinical way. And those were the folks that were like, I don't know what this is. I don't know what this feeling is. I've heard of a coping skill. What's a coping skill? And so while there is a risk with having previous mental health diagnoses and experience, there's also an additional protective factor that we can tap into, again, as those supportive folks in a family's life. Any questions or comments before we move to the next slide? Okay. Real quick, I'll go through some of the presentations of some of the different PMEDs, just again, so we have an awareness so we can have a starting conversation with our families. So with postpartum depression, what we're looking for is, or what we're seeing is like persistent sadness, guilt, hopelessness, fatigue, sleep changes, appetite changes, loss of interest, and things like that. Now, some of the physical things can be a little bit more difficult to identify because that adjustment period is also associated with fatigue and sleep changes because there's a newborn baby. And this is where having that conversation and being really open and talking with mom and partner or mom and supports can really help you recognize if this is fatigue that's associated with the transition or fatigue that's associated with depression. And a really interesting fact is, and something that I think, again, as helpers, we can hold on to is a specific risk factor for postpartum depression is perfectionism. So folks who go into all of their activities and all of their life goals with this idea of like there is a limit of perfection and I can obtain that. When they get into parenthood and it doesn't look that way and they start to realize that perfectionism either isn't available or isn't real, there is that slip into depression. So just keeping that in mind when you're thinking about the folks that you support, if perfectionism is there and something that you've identified with them, this may be one of the conversations you want to have with them. Perinatal anxiety is excessive worry that feels uncontrollable. It's a fear that something bad will happen to the baby. And some of the typical symptoms related to anxiety. So racing heart, restlessness, nausea. And postpartum anxiety is usually a little bit harder to diagnose or to see because parents hide it. And it's also wrapped into like that baby blues thing of like, oh, everybody's anxious when they have a new baby. Everybody's anxious, bringing baby home. And again, oftentimes it's going to take having conversations with a larger support system for you to start getting information and details for you to recognize that there may be a little bit more something present that needs to be supported. Postpartum PTSD is usually associated with a traumatic birth. So again, a unscheduled C-section, a NICU stay, complications during birth or after birth, and even sometimes past trauma related to sexual assault and those types of things. These symptoms are going to look like flashbacks, avoidance, hypervigilance, and like emotional numbing. So what the emotional numbing looks like, again, is that hesitancy or that inability to bond with the baby. I'm going to do OCD and postpartum psychosis together because sometimes it can be a little difficult to identify them and to tell them apart. And then one of the things to keep in mind is that, again, in our position as helpers, as parents, as teachers, as supporters, it's not our job to diagnose. So none of the things we're talking about are for diagnosis. It's for you to recognize like, hey, there may be something else happening here and it's time to have a conversation. So with postpartum OCD, what you're seeing is like intrusive, unwanted thoughts, often about harm coming to the baby. Folks who are experiencing postpartum OCD will have like reassurance seeking. There'll be compulsions of checking and monitoring and cleaning. And the parent's distressed by these thoughts. And that's the most important thing. The parent is distressed by the thoughts and they're unlikely to act on them. And this is very different from psychosis because postpartum psychosis are the hallucinations and delusions, right? And so an example is a mom with postpartum OCD may be very anxious and scared about contaminating her breast milk when she's storing it. She believes that, if the breast milk gets contaminated, her baby will die. So she washes her breast pump repeatedly, like over and over again. She's always asking, maybe she's asking dad all the time or her mom all the time, does this milk look okay? Is this milk okay? Like, how does this look to you? That's what OCD, postpartum OCD looks like. Postpartum psychosis would be mom thinks her breast milk is poisoned, and so she's not feeding the baby, right? So that's like when it becomes an impairment and it disrupts the function of mom being able to care for the baby, and she believes it, right? And believes it in a way that it's going to bring harm to the baby. That's when it's the difference between OCD and psychosis. And then we're looking at postpartum bipolar. What you're looking for, what you'll see is like those cycles of mania and depression. So mom will be really low, right? Really severely depressed, trouble getting out the bed, not answering the phone, trouble caring for herself, lack of eating, lack of sleep, or increased sleep. And then there'll be a swing to the complete other side where mom is like, I can do everything. And, maybe she's making 16 doctor's appointments in one day, or she's trying to clean, like it will be a complete swing from a depressive mode to a manic or hypomania mode. And again, as folks who have relationships with our parents, who are able to see our parents in various states of existence, we're the ones that can be like, hey, this feels very different than it did 2 weeks ago. I wonder if something else is happening with mom. Again, just enough for us to start the conversation. The other thing I'd like everyone to keep in mind is that postpartum. Oh, I'm sorry. Was there a question? Okay. PMADs are not as common as baby blues. Again, baby blues is like 80%. PMADs are coming in the most significant PMAD is postpartum depression, just because it's the one that folks are probably most familiar with. But even that is coming in with about 12% of parents who have gone through postpartum or perinatal experiences. So these experiences are not common. It doesn't mean they won't show up, right? It doesn't mean that we shouldn't be prepared to at least identify and have conversations about them, but they're not common experiences, as common as, again, like baby blues are. All right, so any questions about the PMADs before we go to the next slide?
Good morning. Yes,
I have.
Hi. I just was wondering because a lot of times we have moms who are like in denial if it's picked up in the hospital.
Yeah.
Trying to get them to feel comfortable enough to trust that the doctors know what they see. How do you conversate that piece? Because sometimes they really don't, like, there's nothing wrong with me. Nothing's wrong, but they don't feel it. But the doctor is witnessing, and I guess either blood work or the way they respond to the delivery or whatever.
Yeah, that's a great question. And a lot of it goes back to the questions on the Mentimeter, and what I would lean into is like, what does trust look like between your client and that provider? Do they have a trusting relationship where in all other cases, maybe your client was very much able to intake the information, but in this instance, they're not? Or is it they've never had a very trusting relationship with a doctor? They go because they know they have to go, but there's not that level of trust where they do believe the things that their doctor is saying, right? And so, again, as someone who has a relationship with the client, I would just be very curious about what their concerns are, what their fears are, and even sharing what you're seeing, right? And not to like gang up on mom and like negate her experience, but to say like, hey, mom, I have noticed that, in our last few conversations, you've been a little bit more withdrawn, or I've noticed that you don't make eye contact with the baby. And letting her know that you're seeing some of the same things the doctor is seeing, but in a very supportive and like trusting way, right? We really as folks that have a more intimate relationship with our clients, we lean into that relationship to have challenging conversations and hope that in the conversation she has with you, there'll be some trust kind of relayed to the doctor. Another thing would be if mom has a release, and she's okay with it, I would reach out to the doctor and you have the conversation with the doctor and see what they're saying so that, again, that information can be shared with you, from the doctor, because there may be more trust there. They may be more likely to hear what you're saying versus what a provider is saying, because we know there's a lot of stigma. We know oftentimes the fear is that PMADs and being identified and diagnosed with one, the first thing people think is like, they're going to take my kid, right? And so that's a reasonable fear that she may have with a provider that she may not have with you. And so I would lean into your relationship to be able to have those conversations. I would find providers that they do trust, right? If they're wanting, or if you think some sort of mental health intervention would be helpful, I would work to find mental health providers that you trust so that you can say, this is someone that I know, this is someone that I've worked with before, and I trust the way that they work. But like the short version of that is like lean into your relationship with mom in order to get her to be more open about what other folks are seeing.
Okay, thank you for answering that question. I know there's probably new family support workers or people that are new to this field, so I just thought I would put it out there
Yeah,
in
I
case someone
appreciate it.
doesn't know how to word it and get it out there to ask the question. So that's why I did
Yeah.
it. Okay,
No,
thank you.
absolutely. Thank you, Yvonne.
You're
Stephanie, I see your
welcome.
hand up.
Yes, I don't know if it's a question or just a statement. I'm not really sure yet, but I guess can you also talk a little bit about um, or just putting it on people's radar that it's not just about the moms when it comes to postpartums, that it can be dads, it can be non-birthing moms. I think a lot of people do not realize that, and when they don't, those type of people aren't necessarily given the help that they need or even having those conversations because they weren't the ones giving birth.
Yeah, absolutely. And that's a great point, Stephanie. And I think I talk about it a little bit more in depth in another slide, but you're absolutely right. When we as helpers, as case managers, as support folks are looking and being supportive to families, of course the focus is going to be on mom initially because that's the one that's having the baby and doing the caring, but we've recognized that other folks in the family can be impacted by postpartum and perinatal mood and anxiety disorders. And specifically, dads, and then again, folks that may have gone through surrogacy or parents that are adoptive and things like that. An adjustment to a baby is an adjustment to a baby. A lot of the reason that the focus is on moms is because there's also that hormonal shift that can trigger some of these PMADs to be present, right? But we also don't ignore environmental factors that can trigger PMADs to be present. And dads are definitely part of that, even if it's a co-parenting dad, right? It may not be a dad that's necessarily living in the home with mom, but there's still an adjustment, right? There's still things that are activated by the introduction of a new baby. And so, yes, Stephanie, it's very important that when we are screening and when we're having conversations, we're talking to the whole unit. We're talking to the whole family, because while anyone can't necessarily be diagnosed with a PMAD, anyone can have an activation of a mental health disorder because of adjustment, right? And we want to be sensitive to everyone that is part of mom's life, the baby's life, their community, that may be at risk for developing some sort of mental health concern. Yeah, it's a great point. Thank you, Stephanie. Any other questions before we move into the next slide?
I had one.
Yeah.
For those who are already diagnosed with these conditions, what might that look like in a difference from what it was like prior to their pregnancy? I'm assuming it's in a more increased level of, say, for someone who's bipolar diagnosed before the baby, more severe ups and downs. So what might that look like with the already diagnosed?
Yeah, and that's a great question, Christine. I think there's two things that research shows. Research shows that it'll either be, like you said, increased, so like more severe, or it will feel very different, right? So like the depressive symptoms for maybe someone whose depressive symptoms displayed as agitation and withdrawal, their symptoms may start to display in extreme fatigue and sadness, right? Like one of the things that we've learned about depression specifically is that more likely for women of color and Black and brown women, depression doesn't always show up as sadness, it shows up as agitation, right? And so then we have a new mom who maybe has a prior diagnosis of depression, who doesn't necessarily feel agitated, but now she feels sad, right? So the symptoms may show up in a different way. So there's an intensification and then a development of new symptoms. And again, as the folks who are providing support, what's important is that we are having conversations with our families about what's already present, right? We're putting it on their radar that, yep, maybe mom managed depression in her 20s and it hasn't been an issue. And now she's pregnant and we know that that's a risk factor. Or maybe dad is currently depressed, or maybe dad's managing anxiety, right? And the introduction of the new baby may kick up those anxiety symptoms where before they felt manageable, they may begin to start to feel unmanageable. So a lot of that is having those conversations with parents beforehand, if there is already a diagnosis, so they're aware of like what the shifts may look like. And so that you can be aware of what the shifts may look like. That's a great question. Any other questions? All right. So you're going to see, if you are keeping your eyes open and kind of having these conversations, there are a couple of things that you'll see that will help you say like, oh, there may be something going on here and we may need to have another conversation. So some of the emotional behavior, you'll see a lot of crying, and crying more than usual, right? Maybe you're checking in on the family and mom has been crying the entire time you've been there, and not like weeping, physically crying, but like even just being tearful the whole time, right? That's one of the signs of like, okay, there's something present for mom and it's feeling a little bit unmanageable because the entire time I've been here, she's been tearful or crying. Irritability and agitation. Again, one of the things that we know is that when there is an increase in symptomology in any of the disorders we talked about, that agitation and irritability kind of increase as well. Folks don't know what's happening. And so their initial thing is like to create space. And that doesn't always come out with, hey, I'm not feeling great. I need 30 minutes to myself. Sometimes it comes out as like yelling and being really angry and pushing people away that way. And connected to that, there'll be withdrawal, right? So there may be withdrawal from the partner, there may be withdrawal from the family, and that goes on both sides, right? Maybe mom isn't managing PMAS, maybe she's adjusting pretty okay, but dad's super withdrawn, right? Dad's the one that's not really showing up to the family events. Dad's the one that's not coming down and sitting with mom and the baby. So looking for that withdrawal and that agitation and the crying from everyone, like you said, Stephanie, from everyone that's involved, not just with mom, but those are some of the major like emotional behaviors that you'll see. The physical behaviors, again, get a little bit more difficult to understand because so many of them are also part of the natural transition to having a baby introduced into the family. So there's, again, the lack of sleep. Nobody sleeps when there's a newborn in the house, right? Like that's just not happening. But this is where that nuance comes in to like when there are opportunities to sleep, are folks sleeping? And we'll talk about like the nap when the baby naps thing in a second. But like changes in appetite, right? Again, nobody eats when there's a new baby around. However, when there are opportunities to eat, are folks taking the time to make sure they're eating? The big one, and this goes for mom and dad, is not making eye contact with the baby. Like, let's say you're there, they either, if you're a home visitor, you go out to the home, or they come into your office with the baby, and let's say mom starts to breastfeed and breastfeeds the baby and never once looks down at the baby, right? Like we know one of the things we look for is that, when there's breastfeeding, there's the occasional eye checking and looking down and making eye contact with the baby. That's why breastfeeding and feeding in general is one of the bonding behaviors, because there's a lot of eye contact that's happening. But let's say, again, you're with mom and she's not making any contact with the baby. You're with watching dad, and maybe mom gives baby to dad to feed, and dad's not making any eye contact with the baby. And not in like the way that they're making eye contact with you. Like, you've had eyes on them. You've been watching them through this whole process, and they're not making any eye contact with the baby. That's a huge flag. I don't like to say red flag, but that's a huge flag to say like how there may be something else going on here. And then changes in interaction. And this is an important one. And this is where your relationship with the family will come in to be really important, because of course you're looking for like lack of bonding with the baby, but you're also looking for like, how do they show up differently with you? So if, let's say, the family was super engaged before and now they're a little bit more withdrawn, or vice versa. Let's say they've always been a little hesitant to engage and now mom is like chomping at the bit to talk to you. Paying attention to those shifts and how they show up with you, but also how they show up with each other. Those will be some of the things that you can look for to say like, hey, we may need to have a deeper conversation about what may be present for the family right now. Any questions for that slide? So again, we know that PMADs being untreated can have negative impacts with the parent and infant bonding. It can disrupt childhood development, and it can disrupt family executive functioning. And I think, again, that goes back to the idea that even if, we look at PMADs as something that is hormonally triggered and chemically triggered for moms, it doesn't mean that dads don't have an adjustment period that can activate a mental health concern, right? And so it's important that we have an understanding of this, again, not to diagnose, but often because the nature of our work, one, we usually have more intimate relationships with our families than their PCPs or their OBGYNs do. And two, because oftentimes we see the parents before their providers see them, right? So if you think about moms, their PCP or OBGYN appointment post-birth isn't for 6 weeks, right? When you think about dad doesn't have a checkup after the baby's born. So like, there's really no screening for if dad's having any mental health concerns. We know that like sometimes during during a baby's first few checkups, they'll have a screener for the parents there. But we also know that pediatricians aren't prepared to provide support and appropriate referrals to parents who may screen positively. And so it's important for us, again, as folks who have those relationships with parents, folks who are seeing the parents oftentimes before their own providers do, that we are the ones having those conversations and screening, because early treatment and early intervention is the most successful factor when it comes to successfully taking care of a PMAD or an adjustment or a mental health concerns with parents. We also have the opportunity to observe the family very intimately, again. Because of the nature of our relationships, whether we're home visitors or we just, the families come to the office, we often see that interaction, right? We're not just seeing mom or dad for 15, 20 minutes. We're with them sometimes an hour a week. So we have a deeper understanding of how the family functions and how they operate. And we're the ones that can pick up on those shifts that other folks may not be able to see, which puts us, again, in a really great position to say like, hey, mom and dad, the last few times I've came, dad wasn't downstairs and he's usually down here talking with us. Or I've noticed that, mom hasn't been talking as much in our sessions. I'm just curious how you guys are feeling, right? Again, not to go into any diagnosis, but to lay the groundwork to start to have a more open conversation about if there are something present that would require a referral. Any questions for this slide? So one of the most important aspects of taking care of parents who are navigating PMADs, taking care and caring for folks who are parents, is being proactive, right? So we're not waiting until baby is born and, now we're starting to see symptoms. We're having conversations with families way before, like as soon as we find out they're pregnant, as soon as they come to us, right? Even if it's a family that we get postpartum, we're having these conversations really early. So I think going back to Christine's question, we're identifying if there's existing mental health concerns, right? We're wanting to know, like, is this something that you've had to deal with? What does your mental health history look like? And not in like a newsy, I just want to know about your life way, but in a how can we pull from how you've managed your mental health before to make sure you're supported if something is to come up now. Creating a support plan. Support plans are amazing, and your support plan should include, for folks who have existing mental health concerns, what do I know about when my mental health shows up, right? What do I know about when my depression gets big? What do I know about when my anxiety gets big? What do I know about what are my signs that I'm maybe shifting from depression to mania if we're talking about bipolar? What are some of my obsessions that come up when I think about OCD? So identifying, what those shifts are. And for parents that who haven't managed mental health before, having them understand what some of those warning signs are, right? So part of the support plan can be, I understand what postpartum depression looks like. I understand what postpartum anxiety looks like. So that even if they, again, aren't used to managing these things, they have something that they can go in and check. Support plan also includes, like, again, how are you caring for yourself? So it's not a myth, but it's not a well discussed suggestion, the idea of like you sleep when the baby sleeps, right? For folks that are nappers, sleeping when the baby sleeps is great. But for folks who aren't nappers, sleeping when the baby sleeps can become very frustrating because now they're like, I'm supposed to be sleeping and I can't sleep and there's something wrong with me. If you're not used to napping, sleeping when the baby sleeps is not going to be something that comes easy to you, but that's not often talked about. And so when you're talking about your support plan, it may not be sleep when the baby sleeps, but it may be rest when the baby sleeps, right? Maybe you're just sitting down, you're not reading, you're not on the phone. Even if you're just like laying down, but your eyes are open, maybe your eyes are closed, right? But you're resting when the baby sleeps. How are you going to make sure that you are getting stretches of sleep? So we know that PMADs and mental health escalate intensely when parents aren't able to sleep, right? So how are we creating a plan to make sure mom and dad can get at least 4 hours of uninterrupted sleep? That means if mom is breastfeeding, she's pumped and no one has to wake her up to feed the baby. It means that if dad is sleeping, that no one's waking him up to change the baby, then no one's waking him up. Like, it's making sure that there is a plan in place to make sure both parents can get 4 hours of sleep, if it's possible. If not, who are the supports we can pull in, right? How can we make sure that mom is at least getting a couple hours of sleep, or dad's getting a couple hours of sleep, because we know that is protective. So having the conversation with your families beforehand, creating a support plan that is accessible and reasonable, and focuses on what they have access to. I think, I forget who mentioned it, but like involving support people and recognizing that just because someone is part of the family and excited about the baby being there doesn't mean that they may be a helpful support person. If they don't believe in mental health, if they don't believe that PMADs exist and it's nothing more than baby blues and mom just has to kind of push through, that may not be a support person you want to have on the support plan, right? But maybe there's a best friend who is like, no, girl, I've been there. I know exactly what it is. I can help. Maybe there is a neighbor. Maybe there is a therapist that's already there that's like, yeah, we need to increase our sessions from every other week to every week. What are the community supports? So in Philly, we have Latch Cafe, which is open to any mom with a baby. They say 0 to like breastfeeding, but we also know that the folks that run Latch Cafe aren't going to be like, you can't come in because your baby's 3, right? So what are those community supports that folks can connect to if immediate family isn't an option? And part of that, involving the support people, can be part of your support plan. Coordinating existing services. So again, if there's existing mental health concerns and someone who has a therapist already, you're going to want to connect with them, so that if there is a crisis, if there's an emergency, or if you're just monitoring, that you can make sure that your client is connected to their mental health provider. If there's an OBGYN, if there's a caseworker, like, you're really wanting to make sure that everyone is connected so that no one is left out and no one's in the dark when the parents need additional support. It's a really great way to kind of pull up the flag and say, like, hey, the family's struggling. I need all hands on deck. And we know who all hands on deck are, because we're not trying to figure it out when the crisis arrives. Again, having those conversations proactively about what may be different with a new baby. So if we're talking about someone who has existing mental health concerns, we're talking about like, yeah, we know you have depression and you've been managing it. It may feel a little bit different with baby being here. Again, you have a parent who has diagnosed bipolar, and maybe they haven't had they've been kind of stable for the past few years, but we also know that medication can start to work differently or is impacted by pregnancy. And so one of the conversations you may want to have is like, hey, you're pregnant, you're on medication, your medication may start to feel a little wonky now because the hormones have changed, because your body makeup has changed, and having those conversations so that they're prompted to have conversations with their providers. And again, not waiting for the things to blow up. And then on the other side, for folks who don't have existing mental health concerns, again, exposing them to what the PMADs are, talking to mom and dad, like, this is what the PMADs look like. This is what you can expect. You can expect to not sleep, right? You can expect that your schedule is going to be a little wonky. How are you going to take care of yourselves? How are you going to communicate your needs with your partner and also with the folks that are here to help you? Encouraging realistic expectations. So again, and this is leaning into those parents that may have the perfectionism bug of, yep, you had this nursery beautifully created and you have all their clothes all ironed and nice and ready to go. And your first few weeks home may be a mess. Your house may be a mess. Dishes may not get washed. There may be diapers in places and other than your diaper pail. What's it? The diaper genie. There may be diapers in and around the diaper genie, right? But helping parents to understand that it's okay for things to be a little bit messy. It's okay for things to be a little bit wonky. And not to expect everything to continue to be the way it was before a baby was here, because there's a baby here now. And again, psychoeducation. And this is really takes into context everything that we've talked about, but really making sure that you take time to talk to your parents about what the adjustment looks like. Especially, and I think, again, to lean into what you said, Stephanie, about talking to dads too, like, one, so that they're aware for themselves, and two, so that they're aware for their partners. Even if, again, it's a co-parenting situation, talking to other family members that are part of the support community. Because we want everyone who is supporting the family to understand what PMADs are and how we can support them, how we can take care of them. But also for themselves, right? Again, everyone's going through this adjustment and everyone may be open to the experience of developing some sort of mental health concern. I'm going to go past screeners. These are some of the typical screeners. Again, we don't screen to diagnose, we screen to create a baseline or to monitor symptoms, but some of the more common screeners. I wanted to go to, okay, so you did the screener, what happens now? So the most important thing is to validate that whatever the parents are experiencing is present and here and completely understandable that it's here. You validate with psychoeducation, right? This is when you can start pulling in those stats. Lots of parents have these experiences. 12% of moms have been diagnosed with postpartum. However many percent, I think it's 8%. 8% of dads have been diagnosed with postpartum depression, and that could very well be higher. It's just that we don't screen for dads as much as we screen for moms, right? But you're really just wanting to validate and making sure that you lean into the relationship you've built. You want to stay calm and supportive. So a positive screener doesn't mean that you automatically start escalating the plan and calling folks in. It does mean that you're like, okay, this is something that's present and we need to talk about it. And that you monitor your own emotional response, whatever it is, if it's anxiety or fear about having a positive screener, that you're aware of what's present for you so that you can, continue to be present for the family. You're going to normalize PMADs again. Stay curious, present, and transparent. So again, if there are reasons that you feel like you need to escalate, maybe mom is displaying some self-interest behavior, maybe she is having hallucinations and delusions that you may need to escalate, you're going to talk to them about that so that they know what to expect as much as it's safe. But you're really wanting to be as transparent as you can. You're going to tap into existing resources and new resources. And this is where I really lean into like generational wisdom and strength, right? Like, what did your family share with you about the adjustment period of having a baby? What's expected from moms? What's expected from dads? And how does your family support? How does your community support? But really leaning into what folks already know about what this time means for them, in addition to providing new resources. And so again, one of the resources I love to share with parents here is Latch Cafe. They're just a great resource, but having that resource that you know is tried and true and that you can really share with families. And then use the strengths. So identifying what your parents' strengths are and leaning into them to continue to be supportive. So if you know you have a dad who's like super integrated in the community, knows where all the things are, you may want to lean on dad and say like, hey, dad, we need to find mom a support group, or dad, me and you are going to look for a support group for you, right? Like, but really leaning into what those strengths are, so that you can continue to support them. Questions about what to do if you have a positive screener. And of course, I always want to include when to escalate, right? So there may be times where you do a screener and things are fine, but there may be times where you do a screener and a parent does positively identify that they have suicidal ideation, and maybe they have a plan. Maybe there's impairment so severe that mom's not feeding the baby, not caring for the baby. Maybe there is a current swing when we're looking at bipolar disorder where the mania is presenting harm to the family or to the baby, and you do need to escalate. For one, I would always lean into whatever your program requires for escalation. And so whether that is you contact your supervisor, you contact whoever, like what the family's mental health provider is, but lean into whatever policy you have. But I think the most important thing is that you stay transparent as possible with families, that you're open about the concerns and open about your concern, but also you're wanting to keep everyone safe and keep everyone protected and make sure everyone has the support that they need. And to address it immediately, because we know that when these things aren't addressed, they just spiral, they just grow and they take up more space in the family. And these are the things that create long-lasting trauma. So yeah. Any questions about when to escalate? Okay. Any questions in general about any part of the presentation today? Or feedback, comments, thoughts, concerns, experiences? Okay. Well, that's all I have for folks today. Thank you so much for inviting me and hosting me and having me present. If there are questions that folks have that, maybe you're more specific, feel free to reach out to, I think Zulika has my email. I think Christine or Jennifer has my email. More than willing to take folks, individual questions if there's more conversations you're wanting to have. Thank you so much.
Thank you all. Thank you, Bentley. This was amazing. We learned so much today, and this was amazing. All right. Have a great day, everyone.